Welcome to the Doctor's Inn. I'm delighted this morning to begin by introducing our primary person on the show, Dr. Sethi, Dr. Kamaljit Sethi. I'm Marcia Boyles, and I'm delighted to be here this morning. We have a fascinating topic, I think, because it is absolutely pertinent to everybody at some stage in their lives. I suspect this is pain management. Tell us what pain is. Where do we begin with pain management?
So of course, as you said, Marcia, pain is something that everybody will have experienced in their lifetime, some more so than others. And it's an important subject to talk about because it has so many different components. The risk is, of course, that as we talk today, we'll be overly simplistic because we are trying to compact so much information into a very short period of time. Mm-hmm. And so it will be useful if we just start at the very beginning. You know, what are the different kinds of pain, mm-hmm. and how can we handle them? And then, you know, maybe we'll do subsequent programs where we will talk about pain again. This is not our last, but it is our first encounter in talking about pain.
Yes. All right. So this is a general overview.
That's correct.
Mm-hmm.
That's correct. So we're going to try and make this very relevant as to when you have pain, how to think about it, because when you talk to a family member or you talk to the doctor, you have to be able to speak to what kind of pain are you having. So one way to think about this is to think about the location of the pain. By that I mean not a specific organ system, but the different parts of the body where you can have pain, that the pain originates from. So for example, the commonest kind of pain is musculoskeletal pain, muscle strain. So if you're not used to doing something and you've decided you're going to clean up your apartment or you're going to clean a closet, you're suddenly reaching for things, you're bending down, picking things up. And if this is outside of what you do every day, this may cause muscle pain. So muscle pain is very common. The good news about muscle pain is, hopefully, if this is something that you've just undertaken, it's going to be transient and it's going to get better. Mm-hmm. Musculoskeletal pain overall would include things that come from the muscle and from the bones. So mm-hmm. the proximity, muscles are all attached to bones, and so really they go hand in hand. So musculoskeletal is one type of pain. The second kind of pain that is very common here in our community, of course, is joint pain.
Yes.
Arthritis.
Mm-hmm.
Arthritis is one of the most understudied problems in us human beings as we get older.
Does virtually everyone over, say, 70 have some degree of arthritis?
There is, because as we age and all the organ systems in the body age, some increase in bone growth at the site of the joints occurs. Mm-hmm. And so whether or not you have pain, probably you do have some of those changes. Not everybody with arthritis experiences pain. It's mm-hmm. important to say that. Mm-hmm. Some folks will just get deformities and never really actually have pain. But the far commoner type is where there is actual pain. Mm-hmm. Common sites. Mm-hmm. Everybody knows about the knees mm-hmm. and the hips, mm-hmm. the hands, and shoulders, neck. So
back.
So back pain mm-hmm. Is also a type of joint pain, but it's a little different. Mm-hmm. It's more really a regional pain syndrome rather than just a joint. When we talk about knee pain, or we talk about shoulder pain or hand pain, we've got specific joints we're looking mm-hmm. at. Whereas when we talk about the spine, it's rarely a single vertebral space where mm-hmm. we are having pain. Mm-hmm. So it's a little bit more complex in terms of the involvement of the joint itself and the surrounding muscles as well, because they are also having to assist when we have trouble with arthritis. So for instance, when you have knee pain, we know that knee pain can be alleviated if we have strong quadriceps. or the muscle at the front of the leg. If those are strong, we know that the knee will get more support. So the same thing is true of back pain, much more so. So that's really a chronic regional pain syndrome. It may be acute when somebody has a fall and you may have a fracture. So it may be acute, but generally the kind of joint pain we encounter is a chronic one, and one that is most often associated with arthritis. So after musculoskeletal and joints and back pain, a third or a fourth one that we need to talk about is nerve pain. Now, how do we know that something is nerve pain? So one way to think about it is for anybody who's had shingles, for instance, generally will have pain which is very regional. It's along the course of a nerve. Those who have
of a single nerve?
Correct. That is the case in shingles. So the pain with shingles can precede the appearance of the skin lesions and can last for a long time afterwards. And some are familiar with the term post-herpetic neuralgia, which means that it's the nerve that is involved. And that can be at any site. It can be on the chest, it can be on the belly, the back, the eye. We've seen a fair number of individuals who've had problems with the face. Others who would have nerve pain, for instance, could be those who've got diabetes, because with diabetes you develop neuropathy, and you can have numbness in your feet, and you can have actual pain. You can't feel the ground, or you can have a lot of pain. So that there are different expressions of the neuropathy, but pain is certainly one of them. So nerve pain is something to keep in mind. Moving on to other parts of the body which are different now. So bone and joint pains, musculoskeletal pain, they sort of all behave the same way. They're sort of achy, they're rarely sharp and acute unless you've had a fall or an injury. So let's talk about some other kinds of pain. Pain in the belly behaves totally differently. It may be a dull ache, it may be a colicky type of pain. It just depends on which organ system is responsible for the pain. So for instance, if somebody has a kidney stone, they're going to have colicky pain. If they've got something going on in the belly, it's likely to be different. It may be intermittent, it may be colicky. Gallbladder pain similarly can be colicky. So
What do you mean by colicky?
so colic means, you know, when we say babies have colic,
Yes.
sort of griping kind of pain, griping in the belly. And it's intermittent because, so for instance, let's think of a kidney stone. A kidney stone is trying to move out of the kidney and out of the body. So from the kidney, which is sitting here, there's this tube called the ureter. And so the stone goes into the ureter and it sits there. And then when it gets ready to move, a stone is like a burr. It's got all of these irregular surface all around it. So when it tends to move, it sort of pokes the ureter. And you know, when anything pokes you, it hurts. So the stone sitting inside the ureter hurts far more than anything else that's going to hurt.
So
on the
I've
skin.
heard, yes.
Yeah. So the reason I talk about these different kinds of pain is because when you go and you're going to talk about the pain, you have to be able to describe where the pain is. And then the provider who's seeing you is going to have to determine where is it coming from, because that's going to lead us as to how to try and treat that pain. Now, this is not meant to be all-inclusive. There's many other kind of pain, but we're just talking about the commonest types that we encounter.
All right, so we've got the location, the type of pain.
So let's talk about the type of pain a little bit. So pain that comes, as we said before, that comes from the joints and muscles is usually a dull kind of ache. I want to take a moment to talk about chest pain, because chest pain can be an emergency.
Yes.
Because it can signal a heart attack, and that's when the cord needs to be pulled. So the chest pain that occurs with a heart attack is different than the kinds of pain we're talking about. So the chest pain that occurs with a heart attack most often is left-sided, although it can be in the middle, behind the breastbone, behind the sternum. Most of the time, it's just a sharp pain. It does
In the
not.
shoulder sometimes?
Sometimes it can be referred to the shoulder, it can be referred to the jaw, but most of the time it's here. Sometimes it can be in the arm. But it's a sharp pain. It may feel like pressure, like somebody's sitting on your chest.
Constant?
And it can be constant. That's when you want to pull the cord. Now, there are muscles also in the chest on both sides, and sometimes those can cause pain too. But the severity of the pain now becomes important to think about. So if the pain is severe and it's left-sided, and it's associated with any breathing difficulty, any sweatiness, feeling of clamminess, that's the time to pull the cord.
Okay.
So I wanted to sort of do a carve out for that so we keep it different
Yes.
from the other kinds of pain. So most other kinds of pain is just a dull pain. Nerve pain sometimes can be sharp, okay? And obviously we already talked about the colicky type of pain.
Right.
Now as we talk about the type of pain, we also want to talk about severity, because that is going to be a guide as to how we are going to manage that pain. So we rate it on what is called the Likert scale from 1 to 10. 1 is the least and 10 is the highest degree of pain. We are concerned with all pain, but we want to keep it manageable. We may never go to zero pain. We may, but with chronic pain sometimes that's hard. But we want to make sure that we keep the pain level at the lowest level possible.
Of course.
Anytime the pain is 7 or higher, we are extremely concerned about it. It may be lesser and there may be other associated symptoms, but the severity of pain is a very important guide to your physician, your NP, nurse, in terms of deciding, what do I need to do? Do I need to do it this minute, this second? Or can I take some more time to evaluate it and then determine what I need to do? You know, so
Now
do
you
think
say-
of the pain in that way.
You say a 7. Tell us how you're ranking that.
So 10 is the highest. It's very subjective. There is no precise way to do this. It's just your sense of what is the most severe degree of pain versus, you know, a little twinge here, a little twinge
Right,
there
right.
would be a 1.
All right. So I think often we are asked, how on a scale of 1 to 10, how would you rank it?
Yes. So, and it's very important to do that. It's not enough to say it's mild, moderate, or severe, because the gradations are much different. There's a
Yes.
second reason to choose this scale. So, when Medicare looks at hospitals, for instance, to look at patient satisfaction scores, one of the questions is management of pain.
Pain management, yes.
And the severity of pain. You know, how well do you control pain that is higher than a 7?
Yes.
So you want to keep it well under 7. 7 is not optimal, but it's, you know, the barest standard. You don't want anybody to be in that degree of pain.
Right.
Yeah.
All right. That sounds good. Okay, so this is an overview of the range and types of pain.
Right. Right. One other that I want to mention in passing, which I think is relevant to our community and is not often spoken about when we talk about pain, is what is called psychogenic pain. When we don't feel well, then nothing seems right. And if you have a little bit of discomfort, the discomfort can turn into pain. So that's not to say that if you're depressed or anxious that you're going to imagine you're having pain. It's real, because that underlying state of mind can cause the perception of the discomfort to be increased.
We're all less tolerant of pain
Yes.
when we're overtired, overstressed, over.
Correct.
Yeah.
Correct. So it's important to bear that in mind as well, because if you're calmer, then your pain is going to be lesser.
Okay, calmer. Okay, that's something to remember.
Yes.
All right. All right. Where do we go from here with this?
So let's talk about pain management, and that's a very big topic in and of itself, but we'll try and do some broad strokes today and then get into more specifics perhaps in another program. So keeping that in mind, the first category of medications to talk about are, of course, over-the-counter medications. And with over-the-counter medications, there are some medications we've had around for a long, long time.
Yes.
And they still remain very safe medications. So, for instance, acetaminophen or Tylenol is a very safe medication as long as we don't exceed the limits. The problem with pain management with Tylenol that we often find is that folks don't give Tylenol a chance. What I mean by that is, if you've taken one Tylenol tablet for a pain that you're telling me is 6 to 7 out of 10, that pain is not going to go away.
No, absolutely.
It's not going to happen. So even though Tylenol is over the counter, you must give it a chance. So how much is enough Tylenol? So depending on your body size, you've got to take a minimum. If you're taking regular strength, 2 tablets. For most individuals, I think 2 extra strength tablets are probably a good choice. And you have to take them depending on your chronicity of pain and the severity of the pain, 2 to 3 times a day. If you take it once a day and expect that you're going to have relief for 24 hours, it isn't happening. And then it's not appropriate to say, Tylenol doesn't work for me.
I always find with Tylenol and some of the other OTCs that getting ahead of the pain is the best way to deal with it. That if you normally have pain around 8 o'clock at night, take 2 Tylenols at 7.
That's exactly right. That's exactly right. That's why many times we'll say, you know, when you are having pain, take it 3 times a day for 4 or 5 days, and then you can cut back. But if you start taking it every now and then to begin with, you never can get pain control. So in pain management, the first thing is to get pain control, and that is induction of pain control, and then maintenance after that. And the maintenance you can play with a little bit, but not at the beginning. So Tylenol is pretty safe. We don't want to exceed 3 to 4 grams a day. And generally that's a good number. Now, of course, the oldest pain medication is not Tylenol, it's aspirin. And so there was a time when we used just aspirin, and we would give people enough aspirin so that we could maintain enough of a blood level, but it gave us problems with bleeding.
Yes.
So we therefore
intestinal,
stomach bleeding, hemorrhoidal bleeding. So we tend not to use aspirin in that way anymore. As you know, we use it more for heart issues than we use it for pain. So I want to take that off the table. The second category of drugs that I do want to spend some time talking about are what are called the NSAIDs, or the non-steroidal anti-inflammatory drugs. So common examples, Motrin, ibuprofen, Aleve, Advil. And if you look at the ads for Aleve on TV, they'll make a true believer out of you and say that you can take them, they're good for you if you're the FedEx guy or the, you know, the brown man or whatever, you know. And they do work well. There's no question of it. Their efficacy is not to be questioned. But in choosing medications, we've got 2 issues we need to deal with: appropriateness and safety profile. So for the safety profile, with the ibuprofen type of drugs, the issue is if you take them chronically every single day, round the clock, they can cause you problems. Chief amongst them is that they can cause bleeding, just like aspirin can. So we need to be very mindful, and they should be taken with food. The second is when taken chronically, they can cause problems with the heart. There's increased risk of strokes. And a third problem, a third organ system that can be involved both acutely and chronically is the kidney. They can cause acute kidney failure, and they can cause chronic kidney problems. So, you know, we want to use these drugs very judiciously, use them in consultation with the physician. Don't consider because they're over the counter that they are completely safe. So if you take 2 ibuprofen, that's prescription strength ibuprofen. I would write you a prescription for 400, but you could take 2 on your own.
Right.
And if you think 2 is good, some people will think, well, 2 is good, maybe I
Right.
should take 3 or more, or
Exactly.
more often. My husband does that sometimes. He says, well, it's working, why can't I take more?
Right. More is better.
More is better. And you may be able to, but you may be taking other medications that would put you at risk for bleeding and the other organ system problems we spoke about. So very effective, can be appropriate, but we have to keep the safety profile in mind. Right? So generally when we use these drugs, if you do have kidney problems, then we have to be more careful to begin with, because those individuals would be at greater risk for developing further kidney problems or worsening of kidney function.
I think we often think of over-the-counter drugs like aspirin or Aleve as being quite harmless.
Right,
and
right.
they aren't always, as you're pointing out here.
Right. Want to quickly touch on the narcotics.
Yes.
Now-
Oh, yes. My goodness, that's a major topic these days.
It is, and we will do another program where we will just talk about narcotics. But I'm going
that
to
would be good.
talk just in broad strokes about why we are concerned with narcotics. So when you can't get pain relief from the usual type of medications, whether they're prescription strength or over the counter, then sometimes one has to turn to narcotics. So with narcotics now in Virginia, we've got new legislation, which means that everybody who is on a narcotic has to be in a prescription drug monitoring program, which requires.
Is that right?
That is correct.
When
And,
did that take effect?
it's
Recently?
it's been in the past couple of years. I can't recall the exact time, but it's been definitely a couple of years. So the risk with the narcotics, of course, is that they can create dependence. Once you start taking them, can't do without them.
Yes.
Second, you can create addiction, and addiction can occur in kids, not only in adults. Now you might say,
Good
well,
point.
some folks have said to me, well, I'm 95. What's the risk to me? The risk is that if you are addicted, your body cannot do without it, and if you stop it, you're going to get withdrawal reactions, which means your heart rate will go up, you'll start sweating, you'll become cold and clammy, and we don't want those kinds of things to happen. So we have to be very careful with them. So if we take all of those things into account and we think about the common medicines, those that contain codeine, number one, those that contain morphine, number two, tramadol, which a lot of people here used, and now we have to inconvenience them by having to have them go to the pain clinic in order to get the tramadol. We can prescribe the tramadol acutely for 7 days, but it cannot be done more than that. It can be done in Garden Ridge.
Yes.
And it can be done there because it's safe to do so, because there's a single pharmacy. Because you see, a person may take a prescription to several different pharmacies, and different doctors may write different prescriptions. And that's how,
So the dosage,
yes. Yeah, so people may be taking a lot more than what physician A thinks or what physician B thinks. So narcotics we have to be very careful with. So if anybody's ever taken narcotics, you know what the risks are with the narcotics. In addition to the dependence is a high risk of falls. A high risk of falls. So if you are dopey and you've taken codeine or morphine, your risk of falling is high. And we know what falls mean. Falls mean that you can have serious injuries and you may break a hip. And if you break a hip, the risk of severe problems, including heart attack, stroke in that first year, and the risk of dying becomes very high. So narcotics have to be treated with great caution and respect for what benefit they give us and the risk they create. So I'm not going to talk any more about narcotics other than that, and as I said, we'll do another program. But I do want to touch.
I would be really interested, and I think our audience probably would too, in how you can recognize in yourself dependency and or addiction for those folks who, including myself, who are taking narcotics.
Yes. So as I said, it's like when it's time for you to take it, let's say you take it every 8 hours. By hour 6 or 7, you begin to feel a little shaky. You may feel your heart racing.
You're aware that your body is
mind,
telling you.
Yes, your mind is not working right. Those are all signs that you're heading.
All right. Okay.
to
Fair
that
enough.
direction. So we probably just have a couple minutes left, and so I'll say a brief word about the use of steroids. We have folks who'll come and say, I'm having a bad attack of arthritis. Can't I get some prednisone because that always makes
Right.
it go away? Prednisone is a great drug. It's good for short-term use. It's not for long-term use. So you
Okay.
can give it for a few days when you have a really, really nasty gout flare or a really bad arthritis flare, but it is not for protracted use. Very
All right.
short-term use.
What are the effects if you do use it long term?
The major concern would be increased risk of infections, osteoporosis,
Oh.
and we again going down that route of falls. We
Right.
don't want to go there. And we should lastly mention topicals. We talked about oral medications, and we should talk about topicals, skin preparations. Be liberal with yourself when you're using skin preparations. They're not going to cause harm. Your
No, we're talking about cortisone cream and things of that sort.
Actually, we are not talking about cortisone creams. Those will largely work for allergies. They're not for pain. So the pain creams would be, for instance, a non-steroidal that you can put on the skin or on your joint is preferable to taking it by mouth.
I see. All
So
right.
there is, for instance, diclofenac cream that you can get for joints that an orthopedic surgeon may give you, or one of the physicians at the medical center will give you. Over-the-counter roll-ons that you can buy, lidocaine patches.
Yes.
So salon pass patches. Even good old Vicks Vapor Rub, which is good for colds, is also good for rubbing on joints if they hurt, or any other part of your body, and really quite harmless, except for the odor that's attached. So
Yes.
make good use of the topicals. The topicals are your friends and
All right.
the least likely to cause harm, and can be fairly effective. Again, my plea for the topicals is, please give them a chance. It's like taking that one Tylenol, using the one salon pass
Oh, okay.
patch once, and my
Uh-huh.
pain didn't disappear. I didn't go from 7 to 0, so it doesn't work. That's not the response we expect.
Okay, fair enough. And they're inexpensive, and the side effects are minimal, as you're saying.
Yes, yes.
All right, that sounds good. Anything else, Dr. Sethi? I see our time is coming to an end here. Anything else you'd like to cover that we have skipped over?
I'm sure we've left out large areas which we couldn't cover because of the time limitation and
Well, and
constraints.
certainly the
but
complexity of
yes,
the
yes.
entire
But we will
topic.
do another session on pain management. We'd like to hear from you what your areas of concern are for those who are watching. And we'll try and in the next presentation address those specific issues. And if you have specific questions you want to send us, we can have a conversation and we can read some of those questions and respond to those as well. We'd like to do that for you.
Fair enough. I've certainly gotten a number of comments you said that you had as well, and these are very helpful in determining what topics we pick and how we approach them.
Yes.
Well, this has been extremely interesting. I don't think I've ever heard a pain management presentation before, so this was a treat this morning.